Welcome back to another academic video. My name is Leah, Subcommittee of the Academic and Research Team of MDSA. And today, we will be commencing our second episode of CBL Case-Based Learning with Experts here at Teh Orthodontics. Joining us today is one of the leading practitioners of the clinic, Dr. Teh Leok Hui. After graduating from the University of Malaya with her bachelor's degree, she furthered her studies, obtaining a master's degree from the University of Glasgow, UK. She is now a specialist in the orthodontic field. I'm here at her clinic right now, so without further ado, let's go meet Dr. Teh. Good day, Doctor. Thank you so much for having us with you today at the clinic.
Thank you for coming.
It's our pleasure to have you on board with us. How are you doing today?
Good. Looking forward to meeting you all. Excited.
That's really great. So before we get into the main topic, would you just tell us a little bit about your background and how you got into ortho?
Okay. I graduated from University of Malaya with a Bachelor of Dental Surgery. And then after coming out from UM, I worked at Kementerian Kesihatan. I was posted to Alor, working there for 1 year. At that time, at my time, it's not a compulsion to do housemanship, but I chose to do housemanship because I know I want to specialize. So I want to study, I need time to study. So after that, I sat for my membership exam. That time, we only need part 1. And then the requirement was to have 2 years of working experience. So I worked 2 years, 1 year with KKM, and then another year I worked in a private hospital in Penang. And then after that, I applied for my orthodontics in Glasgow. So I did my orthodontics in Glasgow. I got my master's degree and the membership of the Royal Colleges from Glasgow and England at that time. Then when I came back, after I came back from UK, I worked as a lecturer at UKM for 1 year. In fact, I helped to start up the orthodontic department there. Then after 1 year in UKM, I came out and started my own practice. This is the practice. It will be 23 years, end of this year.
How inspiring, Doctor. Thank you so much for sharing that with us. Without further ado, we heard that you have some very interesting cases for us. So why don't we just jump right into that?
Yep. Well, the first case is a girl. Actually, she started her orthodontic treatment in another clinic by a GDP, a general dental practitioner. So about the complaint was, I did not see how it was like when she was first presented at the clinic, but her complaint was the teeth, one of the tooth are very jutting out, so it was very proclined. So the GDP diagnosed it as a class 2 malocclusion. Then somewhere in between along the treatment, I do not know what happened. That I think the GDP tried to refer her to a periodontist, and then I think that made her lose confidence. So then through introduction, someone introduced her to my clinic. So she came to my clinic, and I noticed that her 1-1 has abscess that is pus oozing from the perio. So I tried to do scaling, and then I took an OPG. Well, it was very interesting because the GDP who started the orthodontic treatment for her did not take an OPG before starting the ortho treatment. So I took an OPG and found that actually the bone support for that 1-1 is very poor. So I referred her to the periodontist, and the periodontist did some procedure on her, and actually the periodontist think that the prognosis for the tooth is very bad. She thinks that eventually this girl is going to lose that 1-1. But she's still wearing the braces. Now the periodontitis is under control, but the bone support is of course very weak, and then she is not suitable to do a bone graft for that tooth. So I think eventually we will have to remove that tooth. But now the girl is of course very reluctant to have the tooth removed. The tooth is now hanging on there with the bracket and the wire. So we'll move the teeth into position first, and then we'll decide what she wants to do with the 1-1.
I see. Very interesting case, Doctor.
In fact, then we found out that this girl actually is diabetic. I think she has diabetes type 1.
So you mentioned that the patient is diabetic. Can you elaborate a bit about the orthodontic considerations in diabetic patients and how it really differentiates from a medically healthy patient?
Well, for diabetic patients, what happens is that they tend to get microangiopathy. That means their blood vessels, especially the small blood vessels, get very damaged. So that will lead to things like retinopathy, neuropathy, a lot of pathy. Where dentistry is concerned, people with diabetes, their healing power is much less because blood flow angiopathy will reduce or impair the blood flow to many parts of the tissues. So their healing power is poorer, and when you move the teeth orthodontically, the bone remodeling will also be slower. So that is the main concern. And if it's topped up with poor oral hygiene, they tend to get infection because their blood flow is low, their immune system defense is lower, so they tend to get infection more easily than medically healthy people. And then the infection usually progress to the worst, and they tend to end up with pus and abscess. So these are the main things that we have to think about because of their poor blood flow, blood vessels. So we would prefer to use very light forces, and oral hygiene is very, very critical. We are very demanding on their oral hygiene because they have a bit of poor oral hygiene, they tend to get infection. Whereas for medically healthy people, maybe not so easily for the infection to happen. So we want to get light forces in these patients so that the bone has time to remodel following the tooth movement. And also we may want to compromise on the treatment goals. So we cannot be expecting too much. So let's say, for example, the person has a class 2 with 10 millimeters. If we can reduce it to class 2 with 4 millimeters or maybe even 5 millimeters, we may have to be happy with it. And we will try to avoid extracting tooth.
So clearly it's very important to know the patient's medical history beforehand.
Yes. Not only for diabetes, like for people with heart problem also. Yeah.
I'm sure our audience will really appreciate that answer, especially since Malaysia has one of the highest rate of diabetes in the world. Thank you for the explanation. Move on to the next question. What are the causes of pathological tooth migration and how can it be managed?
Most of the time, more likely, in most cases when the teeth migrate is usually due to periodontitis because of periodontal health. So when there is periodontal recession, alveolar bone resorption, then the tooth support is weakened, then the teeth start to migrate. It depends on the degree of migration. The first thing is what we need to do is to arrest the periodontal problem, to make it stop there, so that the alveolar bone doesn't resolve any further. And then we want to see how much bone support the teeth have. If it's very little, I will advise against orthodontic treatment. They may have to accept where the teeth are, or they may have to take out the teeth and do maybe implant or denture or even bridges. It depends on the condition. So it depends on the degree of the periodontal health. So we may not indicate orthodontic treatment. If there is enough in the periodontal support, then we will also want to see how much support there is. Usually where the periodontal support is weak, we want light forces. We compromise on the goals that we want to achieve. And then we will have to educate the patient in oral hygiene.
So clearly bone support is very, very important in orthodontic therapy. So for our next question, I wanted to ask whether the patient's tooth 1-1, was it mobile?
No, when she came to me, there was already braces on the teeth. So we can't tell whether it's mobile or not. The braces and the wire are holding on to that tooth. But I took an X-ray, OPG, if I remember correctly. I think the bone support on that tooth is not optimal.
Is it possible for us to apply forces onto mobile teeth using braces?
As I said, it depends on how much bone support there is. Usually, if the bone support is less than 1/3 of the root, I would think the prognosis is very bad for that tooth. So maybe one option is, it depends on the whole condition of the tooth, of the malocclusion in the teeth. Maybe one option is to remove that tooth or to avoid orthodontic treatment altogether.
Earlier you briefly mentioned this, but what is the prognosis of the patient now, and is there any chance of relapse?
Well, actually, the teeth improve because you see, the previous GTP actually diagnosed as class 2 incisor relationship, and she took out 1/4 and 2/4, keeping that periodontally compromised 1/1. So we have no choice because she has taken out 1/4 and 2/4, so we need to close the space. Or either that, or we have to put a prosthesis into that space. But she has a great overjet. And the 1/1, according to the periodontist, is already like announced the death sentence to it. Yeah. So I think we eventually will have to lose the 1/1. So I was thinking that we have just retracted. The 1/1 is still there, hanging on the bracket. So we are just retracting the teeth. We are closing the space. The 1/4 and 2/4 space is closing very nicely, and the labial teeth are going in very nicely as well. So we'll move the teeth into occlusion, into alignment, make it like as perfect as we can into class 1 molar relationship, class 1 incisor. Then we'll see how the 1/1 do. Very likely once treatment is all completed, we have to take out the 1/1 and then see what she wants to do, either an implant or a bridge or denture.
That's a very interesting case. Thank you so much for sharing that with us. So that concludes our first case. The second case is about surgical orthodontic treatment. Doctor, would you please tell us a bit about this case?
Well, this girl come with class 3 skeletal pattern, and actually, although the skeletal pattern is class 3, to me it's not very severe, and she has a class 3 incisor and class 3 molar relationship, which is not so severe as well. She can manage to have an edge-to-edge bite. So I told her that we can compromise. We can straighten the teeth, make the teeth into a class 3 incisor relationship with a positive overjet and a slightly positive overbite, and good interdigital occlusion on the buccal side. But the girl she wanted orthodontic surgery. She thinks she can, she can look better than just compromising the teeth. So I didn't encourage her to do orthodontic surgery. In fact, I was trying to talk her out of it, but she wanted it. Her parents also didn't want it, but she was very insistent. She insisted that she wanted the orthodontic surgery, so she had the orthodontic surgery, which the result is quite good after the orthodontic surgery. She looks really very beautiful.
So interesting. So can you briefly walk us through the procedure of mandibular reduction and maxillary augmentation?
Well, for orthodontic treatment, we have to work with an oral surgeon. So for people who want to do orthodontic surgery with orthodontic treatment, they need 3 specialists. One is the orthodontist, and then the oral surgeon, and they need an anesthetist as well, because this procedure, the surgery has to be done in an operation theatre. It's considered a big major surgery. So usually what we do is we have about 1 year plus, 2 years, maybe 2 years plus of orthodontics treatment to decompensate. That means we make the malocclusion look worse, but the teeth angulated correctly to the respective jaw. Then the oral surgeon will correct the jaw, and then after the surgery, they come back for some so-called fine-tuning to make the bite even more perfect, and check the occlusion and all. So post-surgical treatment takes about 1 year, maybe. But nowadays, the oral surgeon that I work with, he is really a marvelous oral surgeon. Maybe you can interview him. He is really good. He's in TTTI's Dr. Liu. He's very experienced. I find working with him very, very good, very easy. Make life easy, when you work with a very smart, very experienced and skillful oral surgeon. So what he does is that most of the cases, he would do surgery first, and then I will do the orthodontics part. So that one will save a lot of time. But of course, not all cases are suitable for that.
Thank you so much for that very thorough explanation, Doctor. So, what are the contraindications in this orthodontic surgery?
You see, one thing, I think psychological part is very important. When we went to see Dr. Liu, with his experience, he was telling the girl that you have to talk to your friends and your parents, your family, people who are close with you, and you have to tell them that you're going to change your face because it looks very different. In fact, I think this girl, initially for the first many months, the father felt like she looks too different. So, but of course the father was already prepared that the girl is going to have surgery. But right after the surgery, he felt that looks very different. So psychological part, not only for the patient, but the people around her should be able to accept and motivate or support her decision. And the last thing you want is that you are doing this and then people around you keep telling you, why do you do this? No, this is major decision. It was a major procedure. You are already looking good. Why are you changing your face? It's a wrong decision you make. And then you can imagine the treatment take about 2 years. And for that 2 years, before they see the final result, they'll be telling you, wrong decision, you have made a wrong decision. Then that will make you feel really like, then you'll get worried, you'll get anxious. Then usually when they are worried, they are anxious, they'll transfer the stress onto the operator, onto the dentist. Then we are going to be stressed and stressful. So I think this is the first part they have to go through. Yeah. Then the second thing, of course, bone health, periodontal health has to be good. And usually I would say if it's beyond compensation, then you have no choice but to do surgery. But orthodontic surgery are usually quite major, so we will usually want them to go for compensation, go for just orthodontics, unless really cannot. Like for example, there are cases where class 3 skeletal with a high FMPA, and they are only biting on the molar, like the 7th or the 6th. They are only biting there, and there's like huge anterior open bite. And because the occlusal forces are all on the molar 6 and 7, so that molar becomes mobile, then in that case you really have no choice. Then I will encourage a patient to do orthodontic surgery. But otherwise, if we can compensate, I think compensate is good enough.
That's a very interesting and important take that you said, especially about the psychological effect of the surgery onto the patient as well as the people around, and including the dentist as well. Thank you so much for sharing that with us. For our next question, how long does it take usually for pre-surgical orthodontic treatment and then post-surgical orthodontic?
I have mentioned, usually pre-surgical is about 2 years, post-surgical is about 1 year. But nowadays, in some cases, they can do it differently. They do the surgery first, and then after that, orthodontics, like maybe 1.5 to 2 years.
I know that you tried not to get her to the treatment. What is the main reason she wanted to get the treatment done?
I think she wants to look good. She wants to look good. But she really looked very good. In fact, with the class 3 skeletal pattern, I actually think she looks quite nice already. She looked quite pretty. She looks intelligent. But after the surgery, of course, she looks also very, very pretty.
Can you tell us a bit about the consequences, like if the treatment had gone badly?
Usually there is some risk, but most of the time it hardly happens. Sometimes you will feel, after surgery, you will feel some paresthesia, that means you feel funny, and usually it's a large area. Then over the months or even years, then the area of funny feeling, funny sensation will start to shrink, and then sometimes it's always there. It will always remain there. You can feel people touching you, but it just feels a little bit funny. So that is the more common complications from orthodontic surgery. In very rare cases, sometimes they have more severe consequences, but I have not seen yet so far. Hopefully not.
Thank you so much for sharing that with us. The 2 cases that you shared with us are very interesting, and I'm sure our audience really enjoyed watching. So we finished with the very intense part of our interview for today. So let's get into a little bit more of a lighter mood, and we'll have a little rapid fire round where I will ask you 10 questions and you just try to answer as fast as you can.
Okay.
Alright.
I hope the question is easy. It makes me feel like I've gone back to the university by far.
It'll be very simple. Alright, we'll get into it. The first question is, can you please describe orthodontics in 3 words?
It's art and science combined.
Alright. So what's one subject you wish to learn more about?
One subject about dentistry or
Anything in general.
Anything. I am now very much into nutrition.
Wow, very interesting. So what's your favorite type of breakfast?
Oh, my breakfast? Wow. That's one I cannot come up fast. I just usually what I do is I take a protein drink.
I see. Very nice. So are you more of an early bird or a night owl?
I am an early bird and a night owl too. I wake up early for exercising. Sometimes I can't wake up, but then I also stay up late.
I see. So in your undergraduate years, which subject were you worst at?
My worst is dental products, dental material. Do you still have that
Yes,
subject?
we have.
Yeah, I really hate that dental material, but that's the main thing about dentistry, right?
Right. What about the subjects that you're best in?
What I like a lot is pathology and oral surgery actually. In fact, when I was choosing to do my specialty, I was considering between orthodontics and oral surgery. When I was working in Alostar at the general hospital there, I really enjoyed oral surgery. But I was thinking that if I am an oral surgeon, the risk is higher, I thought. And then you have to work at a hospital and then sometimes be on call, because when I work there we do deal with a lot of motor vehicle accidents, so sometimes you have to be on call. So eventually I chose orthodontics, and I like orthodontics too.
I see, that's very nice, doctor. So what's your favorite holiday destination?
Anywhere in the world. I like cold weather. I think anywhere in the world. I like to explore the world and see different cultures.
That's nice. So if you could live anywhere in the world, where would you choose to live?
Malaysia. Malaysia is still the best.
Home sweet home. So what does success mean to you?
Oh, success, I think it has to be all-rounded. It has to be in every aspect. Of course, financially, you have to be comfortable. You have to be independent. And then you have enough time to do what you want. You have to be healthy. And you have to have good relationship, especially with your family and the people close with you. And then hopefully also respected in society. I think this a few, and then spiritually as well. I think spiritual health is also very important, because there are things that we don't know, right? And then there are times that we become weak.
Yeah, that's very true. So now our last question is, what is a piece of advice you would like to give to our dental students watching this episode today?
Dental students, advice? Well, enjoy the journey. Dentistry is art and science combined actually. It's a lot of fun, but open up your mind to many other aspects in life as well. Don't just stick into dentistry, otherwise life will become very, very constricted.
Thank you so much, Doctor, for sharing.
Thank you very much.
Thank you for joining us today. We are so lucky to have you be part of our episode. And for the rest of the people watching, thank you so much for watching, and we'll see you in the next episode.